So welcome to Decoding CTO PCI, Case 8. I am Dr. Sharath, Interventional Cardiologist, Medicover Hospital, Hyderabad. So today's case is CTO PCI in post-CABG patient through retrograde via posterior AV groove collateral. So my patient is a 74-year-old. So old coronary artery disease with acute coronary syndrome and underwent bypass surgery for triple vessel disease in 2017. Had LIMA to LAD, RSVG to OM and PDA. But last 6 months patient had a significant exertional angina which is limiting quality of life. Evaluation showed moderate LV dysfunction and coronary artery disease. CAG showed a native triple vessel disease, Occluded Graft to PDA, patent LIMA and patent SVG to OM, but SVG to PDA was occluded. So and patient underwent PTCA with stent from LCX to OM on 20 August, but still his symptoms remained. So this is an angiogram at the time of angioplasty to circumflex to. So you can see LAD is totally occluded from ostium and no entry point in fact, and LCX is filling RCA retrogradely with an epicardial collaterals, but there is a tight lesion in the distal LCX after OMR is in. Yeah. So this is the LAD occlusion and RCA filling from epicardial collateral. And this is a right system showing total occlusion in the mid RCA, and also proximal RCA is diseased. And there is a big RV branch which is coming out of mid RCA. Yeah, SVG to RCA showed complete occlusion with only stump is seen, which is visible here, and SVG to OM. So we can see here, so it's patent and filling OM1. Yeah, so and coming to LIMA to LAD. So this is a LIMA to LAD in lateral view, which is showing good filling into LAD, and also there are a couple of septals which are filling right coronary artery, that's PDA. Here you can see this is the septal which is filling PDA, but Ostial LAD is totally occluded and it's only filling from LIMA to LAD. So coming to the entire anatomy of this CTO along with coronaries. So this is a right coronary artery, so with the mid RCA total occlusion, and if you look at distal vessel, so distal vessel is quite good, and which is filling from epicardial collaterals from LCX as well as septal collaterals from distal LAD, but this part of LAD is filling from LIMA to LAD, and proximal LAD is totally occluded, and there is a stent in distal LCX, proximal to distal LCX, through which we have to access epicardial coronary. Coming to the CTO anatomy, so this is a CTO. The entry point was ambiguous, but there was some calcium which is like tram track, which can be useful in clearing of your ambiguity, and it's a long length, more than 20 millimeters. There's a lot of calcium present, which I'll show subsequently, and there is not much of angulation, and the distal target is quite good and filling from left system, and there are good interventional collaterals in the form of epicardial as well as septal. So overall it's a JCTO. Yeah. So we started this case with dual injection, as distal vessel is quite well visible from native left system. You can see, so this is the CTO segment, there's a disease proximal. There is also disease in the distal vessel, and yeah, there's a good epicardial collateral. Though there are many lobes, the collateral size was quite good, so which is a good interventional collateral. So yeah, we started in this case antegrade wire escalation. Though the cap was ambiguous, you can see the calcium. So this is the calcium. It's a kind of tram track calcium. This is in LAO, and you can see this is in RAO view. So when you have a tram track calcium in two views, two orthogonal views, this itself is enough for antegrade wiring. So we use this calcium for antegrade wire escalation with microcatheter. So it's a Caravel microcatheter with Miracle 6 wire. As the calcium was, there is a diffuse calcium throughout, we used Miracle than Gaia 2, as Gaia is known to struck in calcium. But at this stage, yeah, Miracle wire progressed further into a RV branch. So at this stage, I switched wire to Gaia after advancing microcatheter, but even Gaia also went into RV branch. As I have no clarity on course of the vessel, so this halts my antegrade wiring. So we decided to go ahead with retrograde. You can see here, so the wire ended up in RV branch in both views. So we decided to go ahead with retrograde. And coming to choosing retrograde collateral, so here we have one AV groove collateral, one epicardial but non-AV groove collateral, and also septal collaterals. So if I choose septal collaterals, I have to go through LIMA and then LAD and then septal collateral, because there is a long CTO in proximal LAD. Or otherwise, I have to open this first, this LAD CTO first, and then take this septal course. So this is going to take long time, so you will spend maximum time on opening LAD CTO first rather than on RCA. So for me, it looked like not a viable option. So then I thought of going with these epicardial collaterals. So in epicardial collaterals, this one was good in size. So when size is good, however, maybe the loops we can cross, as it contains all three layers of artery, so chances of perforation also will be less. Having said that, in a post CABG scenario, using a posterior AV groove collateral is very dangerous thing, if you perforate, because you have to maintain very low threshold to embolize this artery if you perforate. Otherwise, it may cause LA tamponade. So we took this. My first choice was this, followed by this second choice, and third choice is septal collateral. So going retrograde through AV groove collateral. So this is the AV groove collateral in RAO view. So from LCX, yeah. So this is a Caravel catheter with CO03 wire. So you can see, and there are loops. We can see how wire is bending, and gradually the wire progressed. And you can see here, so further progression of CO03, and always keep microcatheter beyond 5 millimeters from the tip of the wire, so that we won't injure collateral channel. So with CO03 I could cross all the bends and then went into the distal part of the collateral, and subsequently into the distal RCA. We can see here, so we went into distal RCA, and now I advanced caravel catheter quite easily into the distal RCA. So then we started retrograde wire escalation, and followed by directed reverse cart. So I escalated retrograde wire to Gaia 2, and we can see the Gaia 2 is almost coming in approximation to antegrade caravel. But after repeated attempts at directed reverse cart with 1.5 millimeter balloon, so we couldn't bring retrograde wire into antegrade lumen. So then I upgraded retrograde wire into Harnett. So as there is a lot of calcium sitting in the lesion, so it's preventing successful reverse cart. So we upgraded to Harnett 14, but even that didn't succeed. So then I shifted my antegrade balloon to 2 millimeter balloon and tried reverse cart with Harnett and Harnett 14 and 2 millimeter balloon. There also I couldn't succeed, and then I shifted base of operations to proximal RCA. It's almost like an extended reverse cart going into a normal segment proximal to CTO, and the retrograde wire I switched to pilot, and balloon I switched to 3 millimeter balloon. So despite that, I couldn't bring back my retrograde wire into true lumen. So then we switched to guideliner assisted reverse cart. You can see here, so I'm sending guideliner down, so and then trying to direct retrograde wire into guideliner. I think this is Gaia wire, but we couldn't succeed even there. So when I looked in an orthogonal view, you can see this is where guideliner is, but my retrograde wire is quite posterior. So antegrade and retrograde wire gear is coming into two different planes, and which is causing a difficult reverse cart. So then, I thought of shifting reverse cart into distal area. So shifting base of operations into distal RCA, so that it becomes easy. But as the wire is going into RV branch, I tried knuckling antegrade wire. So you can see here, so we did an antegrade knuckling, but even antegrade knuckle was going into RV branch. You can see here, antegrade knuckle is also going into RV branch. So that's where we were stuck, so it's not useful. So then I decided to go with a retrograde knuckle. This is a gladius wire. Antegrade knuckle is with pilot, and retrograde knuckle is with gladius wire. So you can see here, so this is a retrograde knuckle which is progressing anteriorly, but if you can see in RAO view, antegrade knuckle is anterior and retrograde knuckle is actually posterior, so both are in different planes. This further complicates my reverse cart as knuckle expands subintimal space. Re-entry into true lumen will be further complicated. So retrospectively, I felt this knuckling is not the right choice in this scenario where already you are struggling with a reverse cart despite approximation of the wires. And then I switched to a antegrade 3.5 balloon with conventional reverse cart along with guideliner. So with the Gaia 2 retrogradely. So, and at this stage I could come back into true lumen and then into the guideliner. So kind of retrograde Gaia 2 came into guideliner. But what happened is caravel is struck here. So, and caravel is not advancing beyond this point. So at this juncture I understood, so the entire difficulty is because of the calcium. So that calcium is not allowing your wires to perforate and come back to true lumen. But once we could come back to true lumen, then it is preventing caravel catheter coming through it. So the calcium complicated my reverse cart. So then we exchanged caravel to fine cross, and fine cross could cross, and then we externalized. and after that we dilated with 1.5 millimeter balloon, you can see here, and then we did an IVUS. So now I'll show you IVUS. So this is at the distal RCA. You can see the block all around, and yeah, catheter is in the true lumen in the distal RCA. And as I come proximally, you can see here somewhere here. So yeah, so my catheter is in going into true lumen. You can see here, this is false lumen, and you can see this is the compressed true lumen. So and this is where actually we entered into the subintimal area. You can see this is a true lumen, compressed true lumen. This is a compressed true lumen, and you can also see between the true lumen and catheter, this is the calcium. So this calcium actually prevented, reverse cart despite multiple attempts, and also it prevented, caravel catheter to go across. So, and finally catheter is in true lumen. Yeah, so this is how, so we are from true, false to true. Yeah, imaging is very important in such patients, to optimize stent expansion, especially in subintimal zone. So we marked subintimal zone. This is where distal end of subintimal position was, and this is where the proximal end of subintimal position was. Yeah, so you can see here. So this is the IVUS picture here in true lumen, and you can see here this is in the false lumen. So this is true lumen compressed, and the IVUS is in the false lumen, and you can see here. So this is where, this is the true lumen, and it's all calcium, which in fact prevented my entry, and this is the IVUS catheter, and this is where we reached into the true lumen. There is a lot of calcium you can also see in the lumen, and this is at the proximal RCA. So after stunting with 3 stents, you can see, yeah, this is a final result of RCA. So you can see all the branches are filling distally. So this is IVUS post stunting. You can see distally we have got 5.9 mm square, and then 7.5 mm square. So at this juncture, here we had actually 5.5 mm square, and this is 5.4 mm square, and here it's 8.1 mm square, and this area is actually subintimal. So you can see it's a very eccentric dilatation, and we can also see a lot of calcium sitting here, and the other side there is nothing. So if we try to optimize too much here, so we may end up in perforating the vessel. So suboptimal is still optimal in this kind of scenarios. So then we removed RG wire. So you have to put microcatheter from both ends of RG wire. You can see here, this is kissing microcatheters, and then gradually you withdraw microcatheter from left side and inject, and see there shouldn't be any perforation. So if there is any perforation, you have to maintain low threshold to close it. So learning points from this case are, yeah, tram-track calcium in proximal cap can clear cap ambiguity in antegrade wire escalation. Antegrade wire escalation in mid-RCA CTO can stall due to wire entry into RV branch. Posterior AV groove epicardial in post-CABG scenario should be used when no other promising alternative was present. Reverse cart can become difficult due to calcium. So understanding calcium distribution sharpens your reverse cart strategy, and also to select site for reverse cart. Knuckle wire can further complicate reverse cart by creating large subintimal space. Never use it. And suboptimal area is optimal in subintimal zone with severe calcium on one side. Thank you.